Until quite recently, obesity was widely believed to be protective against fracture as a result of the higher bone mass in obese individuals and also the protective effect of soft tissue padding. However, more recent work has challenged this perception and demonstrated that fractures in the obese population, particularly in postmenopausal women, contribute significantly to the overall burden. And in this talk, I'd like to cover some work on the epidemiology of fractures in obese postmenopausal women, talk a little about their pathogenesis and pathophysiology, and then finally end up with some thoughts, mainly speculations about treatment strategies. I have no conflicts of interest. The relationship between body mass index and fracture is well recognized, and this shows a study from 2005 where you can see with the green line the very steep gradient of risk in underweight individuals, so that the most underweight have a high fracture risk, and that flattens off as the BMI gets to about 25 or so. If you adjust for bone mineral density, you can see the results on the blue line, and you see that the relationship is very much attenuated, although there still remains an independent relationship between body mass index and fracture risk. My interest in fractures in obese postmenopausal women started when I was reporting bone density scans in Cambridge, and I noticed how many of the scans I reported in people who came in with an incident clinical fracture, a fragility fracture, were obese. And moreover, many of them had normal bone mineral density. And apart from anything else, this made giving advice very difficult. If you have an 80-kilogram woman with a humeral fracture and normal bone mineral density, and the fracture sustained during a fall from less than standing height, do you advocate treatment in that woman? Is there any evidence the treatment will work? Does she have a fragility fracture in the true sense of the word? So we decided to conduct an audit in over a period of 2 years where we looked at 799 consecutive women under the age of 75 years who came in with an incident clinical fracture, non-traumatic, and who had bone mineral density measurements. And you can see on this slide, here we've divided the women into quartiles of bone mineral density, with the most obese on the left. And you can see that altogether, about 27% of these women, postmenopausal women attending our Fracture Liaison Service were obese or morbidly obese. Now, this was obviously a retrospective study. The patients were, to some extent, selected just by the nature of the clinic. And so we decided to look at this in more detail in the context of a prospective study. Sorry, I just show you here the bone mineral density in the women with fragility fracture. And here the highest BMI quartiles are towards the right, lowest towards the left. And those with normal bone mineral density are shown in the pink columns. And what you can see is that the obese and morbidly obese women with fragility fracture almost all had normal bone mineral density as defined as a BMD T-score higher than -1. So we decided to look at this in more detail in the GLOW study, and I'll just describe this briefly to you because I'm going to show quite a lot of data from the study. GLOW is the Global Longitudinal Study of Osteoporosis in Women. It's a prospective, multinational, observational cohort study conducted in 10 countries and 17 sites. And basically, this is a practice-based, not a population-based cohort. And all women, non-institutionalized women over the age of 55 years were eligible for the study if they'd visited their practice within the 2 years previously. The study was all done by self-administered questionnaires with all the limitations that includes. And altogether, we recruited over 60,000 women with a mean age of 69 years. And those women have now been followed up for 5 years. In this study, we looked during the first 2 years of follow-up to compare the prevalence and the incidence of fractures in obese, non-obese, and underweight women. And if you just look at the bottom, first of all, you can see that 24% of women in all had a prevalent fracture at baseline. That's pretty typical. And 6.7% had an incident fracture during the 2-year follow-up. And if we look at the different categories of BMI, we can see that prevalent fracture and incident fracture rates were very similar in the obese and non-obese women. The highest rates, not surprisingly, were seen in the underweight women. But if we look at the numbers shown here, you can see that there are very few of these. Being underweight is now a sort of vanishing minority category, and most of the women are either non-obese or obese. So altogether, fractures in the obese women accounted for 23% and 24% respectively of all prevalent and incident fractures. We went on to look at the site of fracture in these women, and the data are shown here, just comparing the obese in pink and the non-obese in blue for the different fracture sites shown along the bottom. You can see that for some fractures, the prevalence was lower in obese women than in non-obese women. This was true for wrist fracture, spine fracture, rib fracture, and hip fracture. But for other fractures, there was a significantly higher prevalence in the obese women. This was true for ankle and upper leg fractures. Despite these differences, just note that even for those fractures where obese women were less commonly affected, we still see quite a substantial prevalence of wrist, spine, hip, and rib fractures in the obese women as well as the non-obese women. Now, on this table, I've just tried to summarize the other studies that have been done looking at fracture site according to obesity. And these are a real mixture of studies. Some are very small and cross-sectional. Most of them actually are cross-sectional, not all. But I've just tried to summarize what the available data show. And if we look in this column, we can see that very consistently obesity has been associated with a lower risk of hip and wrist fracture, in some studies also clinical spine fracture, when compared to non-obese women. And wondering why this might be, for the hip, it might well be the protective effect of subcutaneous padding during a fall, reducing the impact of the fall. For wrist, I think we have to consider how the obese person might fall compared to the non-obese person. Wrist fractures classically occur in somebody who's walking along, they trip or fall over, stumble, they put out their hand to break the fall, and they fracture their wrist. Obese people may well fall in a different direction. They may be more likely to fall backwards or sideways, and they may well also have impaired protective responses to falling. This is mainly speculation because very little research has been done on patterns of falling in obese individuals. If we look at where there's been increased risk demonstrated, we can see ankle comes out pretty consistently, also upper arm. And then, as you'll see, there's some conflict in the literature regarding clinical spine fractures, whether they are increased or decreased in obese versus non-obese women, and this is something that needs further research. We looked in a bit more detail at the relationship between fracture and risk and BMI, using BMI as a continuous variable and using a follow-up period of 3 years. And this just briefly outlines the methods. What we wanted to do was find the best fit for individual fracture sites according to weight or BMI, and actually the two behave very similarly, and also we looked at height. And so the sort of models that were considered were linear models and nonlinear models, which we modeled using cubic splines. And on this slide, we can show those fractures for which linear body mass index or weight were most significantly associated. And we can see here that hip, spine, and wrist fractures have a significant inverse, strong significant inverse association with BMI, whereas ankle fractures have a positive and significant association with BMI. We also looked at pelvic fractures, and this was interesting, and I think the first time it's been shown, probably because in previous studies, the prevalence of obesity was less high than it is nowadays. In GLOW, it was about, I think it was about 23%. And this model was best fitted using cubic splines. You can see that in underweight people, the fracture risk is highest for pelvic fractures, but that after a BMI of about 30-ish, you see a slight increase in fracture risk again. And we saw a very similar pattern also for rib fractures. One important question is, are the risk factors for fracture in obese women similar to those in non-obese women? And of course, clinical risk factors for fracture in non-obese women have been well characterized. And here we compared, in GLOW again, some risk factors, some of the classical risk factors between obese in the pink, non-obese in the green, and underweight women. And you can see that for previous fracture was just as common in obese women with an incident fracture as in non-obese women with an incident fracture. So this is one very strong clinical risk factor. Maternal hip fracture likewise. Interestingly, early menopause was more common in obese women than in the other categories. And then, interestingly, also, use of arms to assist in getting up from a chair was significantly higher in the obese women with clinical fracture, with incident fracture than in the non-obese women. And likewise, they were more likely to have fallen two or more times during the past year. So these data suggested that falling might well be an important risk factor in obese women particularly, and also perhaps frailty or muscle weakness because of the significant increase in the arms assist in the obese women with fracture. And we also looked at comorbidities, which are well-known clinical risk factors for osteoporosis in non-obese women. And we found that many comorbidities, including asthma, emphysema, osteoarthritis, and diabetes, were more common in the obese women with clinical fracture, with incident fracture, than in the non-obese. Another well-known risk factor for fracture in non-obese women is low bone mineral density. And I've shown you already that obese women with fracture tend to have pretty good bone mineral density, but we have to consider this in the context of their body weight. So a high bone mineral density in somebody who weighs 90 kilograms, let's say, may not confer any greater strength to the skeleton than a lower bone mineral density in somebody with a BMI of 50. In other words, the higher bone mineral density in obese people may reflect adaptation to the increased mechanical stresses and loading that the skeleton has to bear. But an interesting question is, if you compare obese women with and without fracture, do the obese women with fracture have a lower bone mineral density than those without fracture? And we were able to do this in the study of osteoporotic fractures, a prospective study of nearly 10,000 women. And we divided them into those women with fractures. These are all obese women, and obese women without fracture. You can see that the age was virtually identical in the two groups, likewise the body weight, and likewise the waist to hip ratio. So what we did was compare bone mineral density in these two groups of obese women. And these are the results. These are bone mineral density T-scores. In the obese women with fracture are shown in the pink, and the obese women without fracture in the blue. And you can see that in all sites in the hip and in the lumbar spine, bone mineral density was significantly lower in the obese women with fracture than in those without, suggesting that there may be some sort of qualitative defect in bone and quantitative defect in those women who fracture. So, as far as we understand it, and our understanding is incomplete, the pathogenesis of fractures associated with obesity seems to be related partly to an increased risk of fall, a greater impact of falling, different sort of biomechanics of the fall, a reduced protective response, and probably also sarcopenia, which I'll say a little about in a moment. And then there may be a reduction also in bone mineral density in those obese women who fracture compared to obese women without fracture. And this may be compounded by a variety of factors such as vitamin D deficiency, which is more common in obese women, secondary hyperparathyroidism, the production of a large range of adipokines and cytokines by adipose tissue, and also the relative immobility of obese individuals. The relationship between adipose tissue and bone is a really active and fascinating area of research at the moment. And there are at least 4 compartments of fat which are relevant to bone health. One is subcutaneous fat, and I've spoken about its role in padding and protection from falls. Another is visceral fat, which produces a number of cytokines and adipokines that may generally have adverse effects on bone. Then there's intramuscular fat, and this is only recently been quantified, but may be relevant to muscle weakness in obese individuals. And finally, bone marrow fat. This is taken from a paper from Cliff Rosen's group looking at bone-fat interactions. And if we look, first of all, on the left, we can see this is a fat cell here. We can see that leptin acts both indirectly via the sympathetic nervous system and also directly on bone, and that these two effects are opposing. So when acting via the central nervous system, the effect on bone is to reduce bone formation, but when acting directly on bone, the effect is to increase bone formation. And whenever I try and teach students about the effects of leptin on bone in humans, I find that it's really a very unclear field indeed. Osteocalcin is produced by bone, and one of its effects on adipose tissue is to increase the production of adiponectin, which reduces fat mass and probably has positive effects on bone. Then we have PPAR gamma, which stimulates the production of fat and decreases bone formation. And then the adipose cells secrete a number of factors, and these may have stimulatory effects on bone formation or inhibitory effects, a mixture of the two. If we look in the bone marrow milieu, then marrow adipocytes also produce secretory factors, which again may have positive or negative effects on bone, and we've already spoken about PPAR gamma. If we look just at the marrow fat, this is, again, a fascinating area of research, and I have to say that most of the data I'm showing you for this have been obtained in animals. We still have relatively little information in humans. But the hypothesis, anyways, proposed by Cliff Rosen and his colleagues, is that marrow fat may have either physiological or pathological effects according to the phenotype and metabolic characteristics of the adipocyte. So the pathological effects may be seen in these conditions, for example, where there's a negative association with bone mass, and this is mediated by negative secretory factors, the pro-resorptive, pro-inflammatory cytokines, free fatty acids, and so on. But under certain physiological situations, particularly puberty, fracture repair, then these cells adopt different phenotypic and metabolic characteristics, secrete positive factors, and may stimulate bone formation. The other thing to mention is that bone and energy metabolism are closely linked. And osteoblasts, and this is meant to be an osteoblast here, have insulin receptors, and insulin signaling leads, amongst other things, to decarboxylation of osteocalcin. This reduces the production of osteoprotegerin, which is an anti-resorptive cytokine, and therefore increases bone resorption, and the acid milieu created by bone resorption further stimulates the decarboxylation of osteocalcin. And the sort of net effect of this is to increase insulin production and sensitivity, and to decrease the amount of adipose tissue. And this is a sort of positive loop, which is quite unusual in physiology. I mentioned visceral adipose tissue as producing cytokines which may have adverse effects on bone mass. And there have been a number of cross-sectional studies looking at correlations between bone density, for example, and the amount of visceral adipose tissue. And this is just one study in obese premenopausal women, looking at volumetric bone mineral density in the lumbar spine in L4 and visceral adipose tissue. And you can see there is a negative correlation, and similar data have been reported in other studies. Of course, this is just an association, doesn't prove anything causal. Now, intramuscular adipose tissue can be quantified using either CT or MRI. And these images show the subcutaneous fat in red, muscle in blue, and the intramuscular adipose tissue in green. There have been surprisingly few studies of intramuscular adipose tissue in people with obesity, but it's probably reasonable to assume that amounts would be increased in obesity and might therefore be relevant to the increased risk of falling and perhaps also the reduced protective response to falling. This is a small study in community-dwelling adults aged 65 or over, in which they looked at intramuscular adipose tissue quantitatively. And these columns just show various muscle groups in the hip and thigh, and compared the amount of intramuscular adipose tissue between the non-fallers in the dark columns and the fallers in the light columns. And in the fallers, the amount of intramuscular adipose tissue was significantly higher than in the non-fallers. So, as I say, it's a small study, but would be consistent with the hypothesis that intramuscular adipose tissue may increase the risk of falls because of muscle weakness. There's also one study which suggests a relationship between intramuscular adipose tissue and hip fracture. This is the Health ABC study, a large study in I think it's just women, I actually forget at the moment, but anyway, if we look at the adjusted hazard ratio here, the subjects have been divided into low, mid, and high tertiles of thigh muscle attenuation by CT. The low attenuation corresponds to higher amounts of intramuscular adipose tissue. And we can see that the adjusted hazard ratio for hip fracture was highest in those with high intramuscular adipose tissue, significantly higher than in the other two. And also there was a significant trend towards increasing hazard ratio with increasing amount of intramuscular adipose tissue. I want to end up now just saying a little bit about treatment of obese women with fracture, because I referred at the beginning to the difficulty I had in making clinical decisions and giving advice about how these women should be managed in clinical practice. We actually looked at treatment rates in women with incident fracture by BMI category in the GLOW study, and you can see that the highest rates, 57%, were achieved in underweight women, 41% in non-obese, and only 27% in obese. And this probably reflects a perception in many people's minds that because of their normal bone mineral density, these women do not suffer sort of classical fragility fractures. The question is whether interventions that are approved for postmenopausal women to reduce the risk of fracture would be effective in obese women, because all the pivotal clinical trials have virtually all of them have included women who are recruited on the basis of low bone mineral density and or fracture, and therefore the proportion of obese women in these studies is very small, and furthermore those obese women who have been included have had low bone mineral density, so are not really representative of the population of obese postmenopausal women with fracture. And there are one or two studies that suggest that obesity may be associated with a lower treatment response. This is one study from Eugene McCloskey. It's a study in which women were recruited not on the basis of bone mineral density, they're community-dwelling older women, and they looked at the interaction between the efficacy of clodronate, which is a bisphosphonate, on all clinical fractures and body mass index. And you can see at low body mass index values, the treatment effect is most marked. There's a significant reduction in the hazard ratio of the clinical fractures. But as you get up to higher BMIs, this effect appears not to be seen. Now, there were obviously fewer people in the obese category, you can see by the 95% confidence intervals, but nonetheless, this study might suggest that efficacy is less in obese postmenopausal women. There have been some also subgroup analyses of pivotal clinical trials, and in this one, looking at denosumab, the rank ligand inhibitor, the women were divided into categories of body mass index and also femoral neck BMD T-score. And if we look at the results in for the body mass index, a clear reduction in fracture was seen in those women with a BMI less than 25. But in the other categories, no significant reduction in fracture was seen. Again, perhaps suggesting less efficacy in more obese women. And if we look at the femoral neck BMD T-score, we see a very similar pattern. So for those with a T-score less than -2.5, there's a clear treatment effect, but not in those with higher BMD. And this has also been noted in other studies. And it may be that because obese postmenopausal women have bigger bones, one possibility is they actually need a higher dose, particularly of bisphosphonates, to achieve the same effect as we see in thinner adults. Obviously, from nearly every point of view, people who are obese should be advised to lose weight. In the case of bone, the situation is rather different because we know that weight loss is associated with bone loss. And so it might be that in obese women who are at risk of fracture, promoting weight loss might actually increase their risk of fracture. There's some evidence that exercise might attenuate the decrease in bone density that is seen during dieting in obese women. And this study shows some data looking at a control group, a group who just exercised, a group who had diet and exercise, and a group who just dieted. And you can see that for body weight, the control group and the exercise group stay stable, the diet and the diet plus exercise group lose weight. But looking at the bone mineral density results here, and these are all hip bone mineral density, what it basically showed was that if diet was combined with exercise, the bone loss seen in the diet alone group was attenuated. So these data suggest that exercise combined with dieting might attenuate bone loss. There's also some data showing that weight loss reduces the amount of intramuscular adipose tissue, which could be assumed to be a good effect. Again, a fairly short study, a small study with a short follow-up, but in these groups of muscle, the people who after weight loss, this is a prospective study, there was a significant reduction also in intramuscular adipose tissue. Finally, we've looked at the association between weight loss of 10 pounds or more on the incidence of fracture during the following year. So this is quite a short time course, and this slide shows those data for fracture at various sites. And perhaps surprisingly, in these women who had lost weight, and there were about 4,000 of them, there was a significant increase in the risk of fracture at all these sites in the year following unintentional weight loss. So I think there is here definitely a red flag about promoting very rapid bone loss in people, weight loss in women who may be at risk of fracture. So in summary, fractures in obese postmenopausal women make a significant contribution to the overall fracture burden in this population. And of course, as the incidence of obesity increases, this will become more and more evident. The effect of body mass index on fracture is site-specific, although fractures occur at all sites, both in obese and non-obese women. The pathogenesis of fractures in the obese requires further study, but increased risk of falling, adverse effects of adipose tissue seem to be implicated. And finally, strategies to reduce fracture in obese postmenopausal women require further study. Thank you for your attention.